اتفضل يا دكتور احمد، هي متسجله. It's more of a medical rather than a surgical issue, but I will try to mention some brief points and open some topics for thought. Portal vein thrombosis, we will talk about the definition, types, prevalence, pathophysiology, symptoms, imaging, laboratory tests, staging, management, and prophylaxis. The definition is the presence of venous thrombosis in the portal vein and or its branches, whether they're intrahepatic or the splenic and spear-mesenteric. Types, malignant, and these will be removed from the waiting list because they're no longer candidates for transplantation, and non-malignant thrombi, and these we will talk about. The prevalence and incidence varies among different studies. It's around 15% overall. The incidence increases with increasing degree of cirrhosis stage. Pathophysiology. These patients have a hypercoagulable state of blood. Both procoagulant and anticoagulant proteins are decreased in liver cirrhosis patients at the same time, depending on the degree of cirrhosis. There is hemodynamic changes in the portal vein with increased intrahepatic resistance, and this causes a lower portal flow as the collateral size and the flow increases and the blood is shunted away. Also, endotoxinemia by damage of intestinal mucosal barrier facilitates bacterial translocation, and this can activate the coagulation cascade. Risk factors include, but are not limited to, a portal flow below 15 centimeters per second, child B and C, a MELD over 13, genetic hypercoagulable conditions, obesity, male sex, diabetes, acute kidney insufficiency, infections, acute on top of chronic liver disease, esophageal variceal sclerotherapy, and after surgery in the perioperative period as a splenectomy or hepatectomy or other. Effects include increased portal pressure with worsen the cirrhosis symptoms as ascites, upper gastrointestinal bleeding, and recurrent bleeding. Also, it causes a decrease of blood flow to the liver, with further liver decompensation. In a minority of studies, it was controversial if portal vein thrombosis is a predictor of worse prognosis in cirrhosis. Symptoms are variable among different patients. They may be severe during the acute presentation, then improve as the condition becomes chronic. Patients may be asymptomatic and incidentally diagnosed in 40% of cases. When they are symptomatic, they may present with abdominal pain, which is usually in a specific area where the intestinal loops are more congested, or diffuse pain, nausea and vomiting, diarrhea, bleeding per rectum, upper GI bleeding, worsening ascites, intestinal obstruction, or intestinal infarction in acute thrombosis. Detection of portal vein thrombosis by imaging can be done by ultrasound, and that's common and non-invasive and an easy tool. Some of the findings include an abnormal echo in the portal vein, unclear boundary with the wall, no blood flow signal on Doppler, blood flow, portal venous cavernous transformation, portal vein expansion before the thrombosis site. The sensitivity is 60% and the specificity is 100%. Adding contrast ultrasound increases the sensitivity to 81%. Computer tomography venography. has a sensitivity of 86% and a specificity of 95%. Magnetic resonance sonography has a sensitivity of 100% and a specificity of 98%. In the past, direct venography was done. It's not routine because it's invasive and only done when an intervention is planned as a thrombolysis. The methods can be indirect by injecting into the splenic and the spermacenteric arteries, or direct by percutaneously injecting into the transhepatic interportal vein or transsplenic into splenic vein, or if there is an enlarged preserved umbilical vein. Laboratory tests include systemic evaluation of coagulation tests as the prothrombin time, international the INR, partial thromboplastin time. They don't fully assess the patient's coagulation abnormalities, so we can add natural anticoagulants such as antithrombin 3 and protein C. A D-dimer level less than 1.82 was found to exclude portal vein thrombosis with a 90% negative predictive value. A thrombin generation test uses tissue factor as trigger and phospholipids as platelet substitutes. It's considered more appropriate for evaluating thrombin generation and represents the balance between the pro and anticoagulant proteins in the plasma. Thromboelastography monitors all kinds of hemostatic functions, so the coagulation, the anticoagulation, and the fibrinolysis continuously to assess the thrombus formation and its solution dynamically. In B, this patient is on anticoagulants and has a long clotting time to start. In C, this patient has a hypercoagulable state, and D is a patient with cirrhosis. Staging or grading of portal vein thrombosis. I must emphasize that the thrombi that are in the right or left intrahepatic branches don't affect the transplant outcome because the liver is removed with the intrahepatic thrombus, so it's not a concern. The concern is the extrahepatic portal vein. So in grade 1, the extrahepatic portal vein has a 50%, less than 50% thrombus partially. Grade 2, it's a complete thrombus in the main portal vein. In grade 3, the thrombus extends to the beginning of the squamesenteric vein. And grade 4, the complete portal and squamesenteric vein are occluded. And this is important for deciding transplant. So what's the relationship between portal vein thrombus and liver transplantation waiting list? Liver transplant surgery is more difficult with portal vein thrombosis, with a higher risk of rethrombosis post-transplant. In stages 1 and 2, transplantation is usually still possible. However, in stages 3 and 4, transplantation is difficult and risky. Stage 3 is a relative contraindication, whereas stage 4 is considered almost contraindicated. The bottom line, on the waiting list, some patients may lose a chance to transplant due to portal vein thrombosis. So why does the patient wait if there is a portal vein thrombosis risk? Well, in deceased donor programs, there is no control over the transplant timing, and that's what's called the waiting list. And living donors also have a waiting period until the transplant is arranged, although it is more controlled. So what's the management of portal vein thrombosis? 30 to 50% recover spontaneously without treatment. But in these studies where they're talking about the thrombus recovers or the patient, the symptom recovers, it's not always clear. Also, most studies have an inhomogeneous group with liver function ranging from compensated to decompensated, with various other factors as the platelets. The question to think about for comparison, though, is withholding versus treatment of portal vein thrombosis in cirrhotic patients not on waiting list. So on the waiting list, they will probably receive the same or more aggressive treatment. Unfortunately, there is no guideline or expert consensus on how to manage cirrhotic patients with portal vein thrombosis, whether on the waiting list or not on the waiting list. But let's see what we can do. On the waiting list, portal vein thrombosis patients can be offered no treatment for anticoagulation or thrombolysis, TIPS versus with a stent or surgery. With no portal vein thrombosis, we may offer no prophylaxis or anticoagulation prophylaxis. These are the options. So let's see the patients on the waiting list with portal vein thrombosis. Anticoagulation aims at reducing the risk factors for thrombosis, which will prevent further thrombosis and allow natural recanalization of the thrombus to regain portal patency. And it will prevent or treat the symptoms. The goal in acute portal vein thrombosis is to prevent thrombus extension. The goal in chronic portal vein thrombosis is to prevent thrombus recurrence with worsening liver function and increasing portal pressure. Anticoagulation decreases mortality, especially in patients with lower Child-Pugh scores. Anticoagulation showed a strong correlation with lower thrombus progression rates and higher recanalization rates in many studies. And it was mentioned that anticoagulation doesn't increase the incidence of bleeding. However, because we cannot tell is the bleeding from anticoagulation or from portal hypertension, this also creates some confusion. But in a meta-analysis, the risk of bleeding did increase from 0 to 18%, but the benefit was 99 to 100%. And in another study, the benefits outweigh a slight bleeding risk increase. What regimens were used? Some used low molecular weight heparin, some used warfarin, some used the new oral anticoagulants. Most of them started early after detection and lasted for 6 months. If we look at some of these studies, we can say on the right side that the recanalization rates were from 30 to 100% using different regimens, low molecular weight heparin, vitamin K antagonists, or even in the 2018, the rivaroxaban. This is a comparison between new oral anticoagulants or with the warfarin, and many seem to have a reversal agent now, which is good. And many of the new oral anticoagulants have been used, and if you look on the right side, they didn't seem to have many bleeding complications. Thrombolytic therapy is another option. If the thrombus is recent and there are severe symptoms, that may be a justification, but it's contraindication of the INR/2 and active bleeding. It's successful only when early, but it's very hazardous. Can be given indirect or direct and requires strict ICU monitoring for bleeding with immediate stopping if bleeding occurs. TIPS is described in several studies after failure to recanalize after anticoagulation if there is more than 50% stenosis or complete blocked segment. However, a patient must be selected, and for a transplant, we don't really worry about the intrahepatic, and that's why it's not so applicable for the extrahepatic, because we need a short segment. Because for success, a patient segment before and after the thrombus must be present for a stent to be placed, and it's hazardous. Surgical thrombectomy has a high risk and is not practiced. Maybe we may need to resect a necrotic bowel. What about patients on the waiting list with no portal vein thrombus? Routine duplex ultrasound surveillance to detect early small thrombi is a very good idea. But should all patients waiting for a liver transplant receive prophylactic anticoagulation? Well, we don't know. Daily subcutaneous enoxaparin could significantly reduce incidence of portal vein thrombosis in the short and long term, but prophylactic anticoagulation is controversial. In conclusion, portal vein thrombosis has adverse effects in cirrhotic patients. Portal vein thrombosis may force patients to be delisted from the waiting list. treatment of portal vein thrombosis is justified with anticoagulation, but careful follow-up is needed. Prophylaxis for portal vein thrombosis for patients on the waiting list is hazardous, but may be given to higher risk patients, which we discussed, and caution should be the approach. Thank you.